Good morning and welcome back, everybody, to the pain track. Before we proceed on to the pain track today, where we have ready for you a host of international speakers, I'd like to go through some housekeeping instructions first. So in the course of this presentation or in this track, if you do have any questions for our speakers, please feel free to click on the live discussion button at the bottom right hand side of your session page, and there'll be a questions tab available. So feel free to key in your questions there. And if your question is directed to a specific speaker, please do indicate the speaker's name before your question. All right, so now I'm going to introduce you to my co-moderator this morning, or my co-storyteller, as I would put it. Dr. Catherine Apino is a practicing anesthesiologist and pain specialist who completed her anesthesiology training at the Philippine General Hospital, after which she completed a pain medicine fellow position at the Children's Hospital at Westmead, Royal Prince Alfred Hospital, and Concord Repatriation General Hospital in Sydney, Australia. She was after that also given the title of clinical lecturer at the Children's Hospital at Westmead, the Clinical School, University of Sydney Faculty of Medicine, for her teaching contributions. She is currently a clinical associate professor, and she heads the pain management services at the Department of Anesthesiology in Philippines General Hospital, and she has also recently joined the Division of Anesthesiology at the Philippine Children's Medical Center, where her project and passion is in leading the establishment of a pain service, as well as creating a pediatric pain training program. Kim's passion lies in fostering linkages to deliver a multidisciplinary approach to patient management and to provide the best possible outcomes for her patients. Kim, the stage is yours.
Thank you, Angela, for your kind introduction, and thank you for having me as your co-convener. This is my first time in ASPA, so I cannot be any more excited to be co-moderating the pediatric pain track. All right, let me begin by inviting everyone to listen in on Little Dee's tale as she helps us to understand pain in children more. Once upon a time, little Dee was a lovely, bright 8-year-old who lived with her dad and mom and little brother in a cozy apartment in Singapore. Her parents didn't quite know when her parents didn't quite know when little Dee started to have pain, but finally noticed it when one day the pain stayed with her and didn't go away. In fact, it got worse and worse, and because no one knew what it was, little Dee and her parents became more and more anxious. With that, allow me to introduce our first speaker for this particular track, Dr. Mark Alcock, who is from Australia. He's a specialist anesthetist and pain medicine physician and the clinical lead in the persistent pain service at the Queensland Children's Hospital in Brisbane, Australia. He has previously completed fellowships in anesthesia and pain medicine at the Royal Children's Hospital in Melbourne, Australia. He was one of the pediatric editors for the most recent acute pain management scientific evidence released in 2020. Welcome again to ASPA 2021, Dr. Mark Alcock, and now I give you the floor.
My name is Mark Alcock. I'm an anaesthetist and pain specialist from the Queensland Children's Hospital in Brisbane, Australia, and I'm talking today on anxiety, distress and drugs in the pain pathways. I have no disclosures to make. To provide an overview for my talk, I'll first of all go into some of the physiology and terminology related to the pain pathways, as well as anxiety and distress. I'll discuss the biopsychosocial model of pain. And then I'll go into my own approach of managing pain and distress in the hospital setting with both pharmacological and non-pharmacological approaches. To start with, some basic physiology. When we have a noxious insult to our body's tissues out here in the periphery, it's detected by specialized neurons in our peripheral nerves called nociceptors. These nociceptive neurons detect the danger or threat and relay these danger or threat signals in the form of action potentials into our spinal cord. At the level of the spinal cord, there's a lot of complex physiology occurring that has a net effect of either turning up or down the volume on the loudness of the danger signals before relaying those danger signals up to our thalamus in the brain. The thalamus has a very important job to do in being the switchboard of our brain. It's receiving huge amounts of information second by second and has to determine which is important enough to be relayed up to our conscious brain and into our awareness, and what information can be filtered out. Danger signals, not surprisingly, are often prioritized to be relayed up to our brain where they can initiate physiology that mediates the experience of pain. So if I had to describe what pain is from a physiological point of view, I would describe it as this electrochemical activity that's occurring up here in our brain. And the physiology that's occurring further down in our spinal cord and peripheral nerves is defined instead as nociception. And so technically speaking, these pathways in our peripheral nerves and spinal cord are not so-called pain pathways, but more correctly described as nociceptive pathways. Nociception can be considered as the link between a noxious stimulus and the physiology that mediates the experience of pain. It's a physiological process that we are unaware of, which is in contrast to pain, which is an experience, and therefore, by definition, we are aware of it. And interestingly, nociception is neither necessary nor sufficient for us to have the experience of pain. So in other words, we can have the physiology mediating an experience of pain up here in our brain that is occurring independently of a noxious stimulus or the state of our tissues. This is the definition of pain that's endorsed by the International Association for the Study of Pain. It's a long and wordy definition that I don't expect people to have in the forefronts of their minds when they're working clinically. But it is a good definition, and there are some points that I wanted to highlight in that definition today. First of all, as I've already mentioned, pain is defined as being an experience, and therefore, by definition, we have to have awareness or consciousness in order to have it. As anaesthetist, I think this is interesting to reflect on because we're often caring for patients under general anesthesia who are unconscious and giving them analgesics such as opioids. So this situation really highlights when we're administering analgesic medications, we're not treating pain directly, we're actually modulating the activity in our nociceptive pathways. Pain is defined as having both sensory and emotional components. We often talk about the sensory aspects of pain, such as I have a sharp pain in my foot or a dull pain in my back, but we don't talk so much about the emotional components, which are the thoughts, feelings, and behaviors that we take as part of that pain experience. And that's ironic, I think, because it's the emotional components that really make pain such a clinically relevant issue and make it such an unpleasant experience. This definition tells us what the physiological purpose of pain is. It's an unpleasant experience associated with actual or potential tissue damage. So in other words, pain is the alarm that our brain sounds or generates when it's detecting damage in our body's tissues. This definition also tells us that our body's alarm system, just like a house alarm or a car alarm, can become sensitized or overprotective, that the experience of pain may resemble that associated with actual or potential tissue damage. So again, what this is suggesting is that we can have physiology occurring up here in our brain that's mediating a pain experience, that's a real pain experience and feels like there's damage or harm occurring in our body. But when we go looking for that damage or harm, the pain experience is either out of proportion to the harm or the noxious stimulus we may find, or there may be no noxious stimulus there at all. Pain can be classified in a variety of different ways, and one of the classification systems is based on the physiological mechanisms occurring in our nociceptive tracts. In this classification, there are 3 types of pain. The first type is nociceptive pain, which is what I described at the start of this talk, where you have a noxious stimulus in the body's tissues that activates our nociceptive pathways to relay danger messages up to our brain that can initiate the physiology that mediates the experience of pain. The other 2 types of pain in this classification are both types of pain where the experience of pain and the physiology mediating the experience of pain is not actually related to what's going on in our body's tissues. Neuropathic pain is where there's been some sort of structural damage to the nociceptive neurons, either peripherally or in the central nervous system. And when we get this structural damage, we get changes in the expression and sensitivity of the ion channels in those neurons. And that can lead to those nociceptive neurons becoming irritable. They can evoke spontaneous action potentials, which can be relayed to the brain as danger signals, or they can generate action potentials in response to just normal sensory information coming from our body's tissues. Nociplastic pain is the second type of pain that can occur in the absence of a noxious stimulus. And in nociplastic pain, there is an alteration in the way these nociceptive neurons are functioning. So structurally, they remain intact, but the way they're talking and communicating with each other has been altered, such that they can generate danger signals even when there's no noxious stimulus present. In the real world, clinically, these mechanisms of pain don't tend to happen in isolation. It's much more common to see a mixed picture of either 2 or all 3 mechanisms. And a really common example of this is someone who's had a major operation and is experiencing pain post-operatively. They will have a nociceptive component to their pain driven by the noxious insult of the surgery. But because they're having a high degree of traffic coming in from their tissues into the spinal cord, the frequency of these action potentials will actually induce changes of central nervous sensitization of the spinal cord, and that will contribute to a nociplastic component of their pain as well. Anxiety and distress. Anxiety can be described in terms of behaviours that we can observe, cognitions that may be expressed to us, and symptoms that patients may report to us or that we may also observe. Regarding the physiology of anxiety, there's a lot of overlap between the physiology mediating an experience of anxiety and the physiology mediating pain experience. And given that that the physiology of these 2 states is so similar, and that pain is also defined as an unpleasant experience, one may consider that anxiety and distress can actually be a normal part of the pain experience. Anxiety and distress can also modulate the activity in our nociceptive pathways. And the best described mechanism of this is through brainstem neurons. In our brainstem, we have neurons with cell bodies in the periaqueductal grey and the rostral ventral medulla that communicate with each other and then can project down to our spinal cord to either enhance or inhibit nociception. These brainstem neurons receive information from various parts of the brain, including the neural circuitry involved in mediating the states or the experiences of anxiety, distress, as well as pain. They also receive information from neural circuitry involved in thoughts, feelings, and behaviours in general. The biopsychosocial model of pain describes the relationship between biomedical, psychological, and social factors and pain. And in particular, it emphasises the bidirectional nature of the relationship between these factors and the pain experience. I think as doctors, we all have a pretty good understanding of how biomedical factors can be related to the pain experience. But when it comes to psychosocial factors, things get a little bit more complicated. But I think it is possible to think about the relationship between psychosocial factors and the pain experience in a pragmatic way. I've already talked about how pain is the alarm that our brain sounds when it's detecting danger or threat. So if we think about pain in this way, it also points to pain or suggests that pain has a role for protecting us. and that pain can be conceptualized as a protective output that the brain can generate whenever it perceives danger or threat. Conceptualizing pain in this way indicates to us one of the fundamental functions of our nervous system, which is vital for our survival, and that is protection. Pain is not the only protective output that our brain and nervous system can generate. Another common example of a protective output is the fight or flight response. There's also another fundamental function that our nervous system has, which is social connection. Social connection helps us build resources for safety, health, and well-being, and it requires skills such as emotional expression, emotional connection, and emotional regulation in order for us to build and maintain healthy relationships. These two functions can at times appear to be competing with each other. For example, if we have mounted a heightened fight or flight response, it can be really tricky to regulate our emotions and connect to people around us in a helpful way. However, when we have good general health and well-being, these two fundamental functions of protection and connection tend to be in a healthy balance with each other and can even complement each other. So with this knowledge and understanding of how our nervous system works and some of the fundamental functions of our nervous system, I use that information and understanding to help me think about psychosocial factors and their relationship to pain. And I tend to think of psychosocial factors as being in two separate layers. First of all, there are factors that have occurred in the past or may have occurred repeatedly over time that have shaped the way our nervous system develops and can disturb that healthy balance between those functions of protection and connection. So factors such as adverse childhood events, neurodevelopmental diversity in certain contexts, the dynamics of relationships, our mental health and social determinants of health are all factors that can disturb that healthy balance and gear a nervous system to be wired more for protection than for connection. And if you can imagine that you have a nervous system that is geared for protection, it may be more likely to generate protective outputs such as pain, anxiety, distress, and the fight or flight response. The second layer of psychosocial factors are dynamic psychosocial factors. So these are things that are influencing the state of our nervous system and being on a day-to-day, hour-by-hour, or even minute-by-minute basis. They can include information coming in from our environment through our five senses. They can be beliefs and memories and other thoughts, or they can be emotions and behaviors. And again, if you have a nervous system that has been geared for protection throughout its development, then you could believe that, see the potential for a greater number and breadth of dynamic psychosocial factors to trigger or push a nervous system state into protection mode more easily. So this information can be really helpful in forming a pragmatic whole life approach or non-pharmacological approach to managing the child or young person with pain and distress. We don't have to do really detailed psychosocial assessments, but just being able to recognize and understand how factors such as complex trauma or adverse childhood events can influence the way our nervous system is wired can really help us as clinicians be empathetic to patients with pain and distress, and also help give us confidence in managing these patients, even in the absence of immediate validation of our actions from a patient with pain and distress. And if we can be empathetic and have an appropriate level of confidence in the work that we do, then that is going to make us more effective at our jobs and more effective at meeting the needs of our patients, most importantly. So when I'm seeing patients clinically on the acute pain round, I'm also conceptualizing pain as that protective output the brain can generate whenever it perceives threat or danger. And with that conceptualization at the forefront of my mind, I am assessing the character of the noxious stimulus associated with their pain, as well as looking for some of those dynamic psychosocial factors that may be sources of threat or may be triggering or pushing a person's nervous system or being into protection mode. And the reality is, in the acute inpatient setting, there are lots and lots of potential dynamic psychosocial factors that can contribute to to that pain and distress. And in this text box, I've listed just a few of those that come up really frequently. So once if we can identify factors like this, we can work out how to manage them or influence them to reduce or mitigate their threat value. But I think we can also do more than that. We can proactively try and foster a sense of safety for our patients in that acute inpatient setting. And that is really focused a lot around trying to enable that fundamental function of our nervous system of social connection. And in the text box here, there are just some of the examples of the techniques that I do, or the strategies that I may use to try and help foster that feeling of safety in what can be a really threatening environment in the inpatient setting. Regarding medications, I don't think there's a need for me to go through each of these individual medications and how they can work for people with pain. I think as anaesthetists, we all have a really good understanding of the pharmacokinetics and pharmacodynamics of these medications. But one thing I would really like to highlight in terms of the analgesics is the way that they work. And that is that they all pretty much modulate our nociceptive pathways and therefore are treating pain indirectly through the effects on those nociceptive pathways. And they do tend to work pretty well when there's a high degree of traffic flowing through our nociceptive pathways. So they work pretty well for nociceptive pain. Some of these medications can work okay for neuropathic pain, and none of these medications work particularly well for nociplastic pain. So when we have, I think that's helpful for us to think about as clinicians. If we have a child or young person who has a high level of distress and anxiety with their pain that we feel is out of proportion to the noxious stimulus, that's a flag to us that there may be neuropathic and nociplastic mechanisms at play, and that whole life approach to management becomes more and more important. But it also means that we should have realistic expectations about what our medications, what our analgesics can achieve, and for us to set boundaries about what we're willing to prescribe in terms of doses and number of medications. So we don't back ourselves into that corner of having a patient on multiple medications at high doses where the risk of drug interactions and adverse effects becomes greater. The one analgesic that I tend to use more than others in that setting of pain and distress out of proportion to a noxious stimulus is clonidine, because I think it is quite a good anxiolytic in addition to it having mild to moderate analgesic effects. If we want to modulate the anxiety and distress directly, there are two medications that are commonly used. Benzodiazepines are medications that I don't use very much at all. And that's because I think they can reduce anxiety and distress, but they tend to, as global CNS depressants, they tend to reduce or depress all of our CNS functions. And I just don't think it's a very sustainable way to manage a person in distress and anxiety with their pain. Atypical antipsychotics are things such as quetiapine and olanzapine, and I don't tend to prescribe these myself, but I do endorse their use when working alongside our mental health colleagues. Those are the medications that I would prefer to see used if there was a really good indication for pharmacological modulation of anxiety and distress in the acute setting. So in summary, pain is our body's alarm system, and the alarm system can become sensitized or overprotective, just as a house alarm or a car alarm can. Anxiety and distress can be considered a normal part of a pain experience. Pain is a protective output that the brain can generate whenever it perceives threat or danger. Psychosocial factors can be considered in two different layers: those that are influencing the wiring of our nervous system over time, and then dynamic factors that can influence the immediate state of our nervous system. A whole life approach to pain management recognizes what may predispose a nervous system to protection, looks for potential threat in the psychosocial environment, and provides a safe feeling environment. And analgesics influence pain indirectly through modulating nociceptive pathways. Thank you.
Kim, I think you're muted, Kim.
Sorry about that. Thank you very much for that very comprehensive talk and focusing on the biopsychosocial model of pain as well in children. This is something that is very familiar in the adult population, but especially, for example, in the Philippines, the biosocial model of pain in children is not still easily accepted or popular. We have a couple of questions, Angela, I think, in our
Mhm.
chat box. Yeah, I'll read one off. So this is from Dr. Viva Mark. Thank you for your wonderful insight into this topic. The question is, do you think that children of anxious parents have more pain than those whose parents are not anxious?
Yeah, thank you for that question. I think there can be a correlation there, but it's never, in pain, there's very rarely very simple cause effect relationships. But certainly, if you have parents who are anxious or have anxiety disorders, that can, the children can have a genetic loading for anxiety as well. And then I suppose the other thing that we think about a lot in our chronic pain clinic, and I think is relevant to acute pain as well, is attachment, or the dynamics of the relationship
Mm,
between a child and their carers. And so we see lots of people who have anxiety disorders but secure attachments, and they function really, really well. When there is insecure attachment, then that can be a situation where a child or young person in a stressful environment may experience more anxiety and distress than a child or young person with a secure attachment. I think
mm,
what that means practically is that, always we're very family centered in our care of children. Obviously,
mhm,
that does mean really connecting with the parents or the caregivers as well as the child, and often and providing support to parents as well. We often see parents and carers get really sleep deprived, for example. Um, Often in a situation like Little D's, I think social work can play a really important role in supporting the parents
mm.
through that experience as well as the children.
Yep. Very, very good points that you brought up there, especially in say, for example, a very patriarchal society wherein mostly it's the that we tend to focus on when talking to. Um, but yes, thank you very much for that. There are a few more questions here. This is from Angela, I think. What dose of clonidine do you use, and do you see any hemodynamic shifts with its use?
So I normally start at a dose of about 1 mic per kilo, and as needed, PRN, kind of six hourly. That's my usual starting dose. And then in a very stepwise fashion, the absolute maximum that I'd go to an award environment, or have gone to an award environment, is kind of 3 to 4 mics per kilo 4 hourly. Um, and I find that if you do that, start at that starting dose of a mic per kilo, kind of 6 hourly, 4 to 6 hourly, then that's generally pretty well tolerated, unless you're really dehydrated or have lots of fluid shifts going on. I don't run into lots of problems with bradycardia or hypotension with those doses, and typically, as we're going up very gently, most children seem to tolerate it pretty well.
Mm, okay, just an add-on question to the clonidine. When would you usually add clonidine? I mean, what analgesics would you already have on board when you start to add clonidine?
So I normally am looking at clonidine if they're on regular paracetamol and an NZ, and then they're on a decent dose of opioid, and if there's still a significant amount of pain, or if I'm just getting the feeling that there is that alteration in the relationship between the severity of the pain experience and the noxious stimulus that we can see. That's when I start thinking about clonidine. So it might be, sometimes it's right at the start.
Mm-hmm.
Sometimes it's happening kind of 2 or 3 days post-op, when we feel as though healing from surgery is well on the way, and you'd expect the pain intensity to be decreasing, but it's still remaining quite high. That's another really common time that I'm introducing clonidine. Um, So yeah, but usually it's I see it as an adjunctive analgesic
Mhm.
and an anxiolytic.
Sure. Thanks for that. We have a few more questions. Angela, would you like to go for the others, or do you want me to just
Yeah,
keep
yeah,
going?
sure.
Yeah.
Yeah, so with regards to, apart from Clonidine, Mark, do you use any other anti-anxiety drugs?
I don't personally know, so I try to steer clear of benzodiazepines, to be honest.
Mhm.
And for a few different reasons. Partly because I think that you run into problems with withdrawal syndromes if you're using them for a longer period of time, and it's a bit of a nastier withdrawal syndrome than from something like clonidine or
Right,
opioids.
right.
Um, and I've also seen a number of children have a paradoxical excitatory response to benzodiazepines as well.
Yep.
Um, so I try to steer clear of them. The other ones that I use tend to be quetiapine or olanzapine, but as I said in the talk, I usually do that in consultation with our mental health practitioners because they're not
Mm.
drugs that I'm routinely prescribing.
Right,
Um,
right.
but I do try really hard with that non-pharmacological approach as well, and I think that I suppose that promoting social connection and trying to help patients feel more like people, particularly as you get more into that recovery phase, you really can make a huge difference. And that's, I think, not only obviously avoiding a lot of the issues with drug interactions and so on, but I think it's really facilitating recovery in addition to managing the pain and distress.
All right. Excellent. Thank you so much, Mark. That was a really good talk, actually. Kim, should we carry on with our story?
Yeah, we have a few more questions. Unfortunately, we don't have the time anymore. So this is a very interesting discussion, and we appreciate all the questions that are being fielded in. But let me go ahead with the story, if that's all right. Keep me company as we explore more Little D's story. So Little D was in pain when she finally went to the hospital. They had to draw blood from her and give her injections and make her lie still for a very, very long time in an MRI scanner. And that was very painful for her. But she tried to be a good girl and held still. Nonetheless, it was all very scary and Little D was afraid. With that, thank you. Thanks for the slide. With that, let me introduce our next speaker who will share with us his pearls for painful procedures in pediatrics. Dr. Yang Yun Jang completed his medical school anesthesiology training clinical fellowship in pediatric anesthesia at the Seoul National University Hospital in Korea. Currently, he works as a clinical assistant professor at the same hospital. His clinical works include cardiac anesthesia, non-operating room anesthesia, procedural sedation, and regional anesthesia in pediatric patients. He has particular interests in perioperative bedside ultrasound, vascular catheterizations, perioperative pain management, and enhanced recovery after surgery in children. He is a member of the scientific committee of the Korean Society of Anesthesiologists and is a general member of other specialty societies, including the Korean Society of Pediatric Anesthesiologists and the Korean Society of Regional Anesthesia and Cardiothoracic and Vascular Anesthesiologists. Welcome to ASPA 2021, Dr. Yang Yun Jang. The floor is yours.
Hello everyone, my name is Young Jang. I'm a pediatric anesthesiologist at Seoul National University Hospital. It is a great honor for me to giving the lecture today, and I want to thank ASPA 2021 for the kind invitation. The topic of my presentation is Pulse for painful procedures in children. I have no conflict of interest. These are the contents of my presentation. First, we'll look at the goal and common problems of procedural sedation for painful procedures. Then we'll move on to the procedural sedation for specific situations. The content of this lecture were prepared based on the following guidelines and textbook. Now we'll start by reviewing the goal of procedural sedation for painful procedures. Despite the remarkable development of the medical field, diagnosis and treatment still require painful procedures. In particular, patients who undergoes both medical and surgical treatment need procedural sedation in various situations, ranging from simple IV cannulation to bone marrow, lumbar puncture, and postoperative dressing. The purpose of procedural sedation is as follows. In painful procedures, the goal of sedation is to minimize pain, psychological trauma, and dangerous movement to ensure patient safety. The level of sedation required varies depending on the diagnostic examinations or procedures. In the textbook, the level of sedation are determined by how the patient responds to external stimuli and whether the patient maintains the airway, spontaneous breathing, and cardiovascular function. However, in the real world, the level of sedation changes every moment. Therefore, we need to understand the specific external stimuli during the specific stages of painful procedures to predict and assess the patient's response. Now we'll move on to the common problems during sedation for painful procedures. When pediatric anesthesiologists were asked to conduct a sedation, that is not an easy case. The patient is usually in poor medical condition or failed in previous sedation attempts. Therefore, the sedation attempt is usually risky, so emergent conversion to general anesthesia should be prepared with appropriate equipment by a well-skilled operator. Children with these underlying conditions are more likely to develop life-threatening complications during sedation. Therefore, care should be taken for these children. Regardless of patient's condition, the most common and critical problem during procedural sedation is respiratory failure. When the imbalance between sedatives and external stimuli deepens the sedation level, it leads to central hypoventilation or airway obstruction. Therefore, the operator should find the optimal patient position and prepare various devices to monitor the ventilation and secure the airway. There is a time lag between apnea and desaturation. When FiO2 is 100%, saturation changes 1 or 2 minutes after apnea. Moreover, pediatric patients have high metabolic rate and low cardiorespiratory reservoir. Therefore, once the SpO2 value reaches 95%, it drops very quickly and cardiac arrest can occur within minutes. Therefore, it is better to check the respiration even if there is a little change in the SpO2, such as 2 or 3%. We all know that end-tidal CO2 monitoring is the best option for respiratory monitoring. Although the device is still expensive, it is strongly recommended during moderate to deep sedation, which is needed in painful procedures. Suction, oxygen, airway, pharmacy, monitors, and equipment as known as SOAPME, SOPME, should be prepared for emergent airway management and conversion to general anesthesia. Now we'll move on to the procedural sedation for specific painful procedures. For minimal sedation, the operator can monitor the patient. However, during moderate to deep sedation required in painful procedures, there must be an independent observer who is well skilled in the airway management and pediatric advanced life support. When the patient undergoes minimally painful procedures such as intravenous line, small laceration repair, or lumbar puncture, the pain is not too severe and the procedure needs a relatively short time. For cooperative patients, localized pain management by amniotic cream or vapor coolant would be helpful. In the others, minimal sedation by nitrous oxide and subcutaneous infiltration of local anesthetics for the procedure side is recommended. Vapor coolant is a handheld spray that projects a skin cooling agent. As the patient feels the cold sensation, the painful sensation decreases. It is easy to apply and acts very fast. However, it is not recommended for prolonged procedures as it can cause cold damage to the skin. Therefore, it is usually for very short procedures such as intravenous line, blood sampling, injections, or small sutures. Nitrous oxide has a rapid onset and fast recovery time and can be applied for prolonged procedures without intravenous access. Therefore, it is still widely used for minimal sedation in children. When nitrous oxide is not available or the intravenous route is not established, intranasal administration can be an alternative option. Many sedatives such as fentanyl, midazolam, ketamine, or dexmedetomidine can be used by the intranasal administration. When the patient undergoes procedures such as bone marrow, fracture reduction, muscle biopsy, GI endoscopy, or larger wound management, the pain is moderate to severe and the procedure can take time. In this setting, moderate to deep sedation is needed. An intravenous access should be established for the sedatives, analgesics, antagonists, and hemodynamic management. I recommend the combination of intravenous ketamine and propofol, as known as ketofol, for procedures with moderate to severe pain. When ketofol is given by bolus injection, propofol 1 mg per kilogram with ketamine 0.5 mg per kilogram just before the procedure shows the rapid onset and stable sedative effect. Oxygen should be given and respiratory monitoring with pulse oximeter and end-tidal CO2 is recommended for safe recovery. In our center, many painful procedures were successfully sedated with ketopol continuous infusion. The concentration is 10 mg per milliliter for each agent and mixed with a 3:1 ratio. The loading dose is 1 mg per kilogram and the continuous infusion rate is 100 to 200 microgram per kilogram per minute with dose titration. And a rescue bolus of 0.5 mg per kilogram can be used. Oxygen and respiratory monitoring is recommended for safe recovery. Additionally, for fast recovery, decrease the infusion rate when the procedure prolongs and remove remaining agents from the IV line after the procedure. This is a recent case of lower and upper GI endoscope in a hospital. The aforementioned catapult infusion was used to sedate the patient while the pediatrician performs lower and upper GI endoscope and biopsy. For research, high-flow nasal oxygenation was used with transcutaneous CO2 monitoring. Usually, we use nasal cannula with endotidal CO2 monitoring. After the bolus dose of 1 mg per kilogram at the beginning, the infusion rate was 150 microgram per kilogram per minute during lower GI examination. The infusion rate decreased to 90 microgram per kilogram per minute during upper GI examination for fast recovery. The patient maintained spontaneous breathing and stable vital sign during 40 minutes of endoscopic procedure without significant change in transcutaneous CO2 level. I want to emphasize the risk of propofol and ketamine from recent literature. Although this data is from the pediatrician, not from the pediatric anesthesiologist, care should be taken when we use propofol and when other comorbidities are present. Also, there is no one universal regimen for all procedures. Each hospital situation, such as the patient, drugs, equipment, procedures, cost, and the operators of sedation, is different. Therefore, it is important to make your own reliable regimens and accumulating experiences in various procedures. For example, in Texas Children's Hospital, they recommend intranasal or IV dexmedetomidine with local anesthetics, IM, IV ketamine, or IV etomidate for painful procedures. A team approach is always important. Even experienced pediatric anesthesiologists cannot handle everything by themselves when problems occur. Therefore, everyone who participates in the sedation and the procedure, including doctors, nurses, and laboratory personnel, should work together for patient safety. Timeout before sedation is recommended to check everything is okay and to share the expected side effects and the role each person will do when something happens. In summary, we need to always be prepared for bad situations. And to avoid those bad situations, we need to understand our patient and painful procedures for optimal pharmacologic management. Do not forget local anesthetics for painful procedures. The combination of intravenous ketamine and propofol is very effective for moderate to severe pain, but needs careful respiratory monitoring. And finally, safe and effective sedation needs not only a good anesthesiologist, but also an experienced team who can solve the problems together. This is the last slide, and these are the pictures of pediatric anesthesiologist and the pediatric sedation team of Seoul National University Children's Hospital. Thank you.
Thank you very much, Dr. Jang, for those very insightful, for your insightful lectures, practical approaches, practical suggestions, with an equal amount of evidence that you have presented. Um, I actually have a couple of questions, if you don't mind. So, have you been requested, or was there any situation where you have been asked to do purely a procedural analgesia without sedation? And if yes, what agents did you find useful, and for what particular procedures would you recommend purely procedural analgesia without sedation? Sorry, quite a few.
Thank you for your question. In fact, I have no experience of pain management without sedation because our department is now expanding our boundary to non-operative room anesthesia and sedation, but there's a little experience in pain management. So, but I have some experience of post-operative pain management. So when the patient is not well tolerated by the IV sedation or PCA, we usually bring the patient to the OR and give some regional anesthesia for where the patient hurts. So that is my experience. Sorry.
My turn to ask a question, actually.
Yes.
Dr. Chang, hi. Thank you very much for your time. I was just wondering about repeat procedures because, some of these procedures sometimes can take a little bit longer than intended. So if, let's say, you're coming to the end of like the 45-minute or 60-minute mark, how do you redose some of these drugs that you've been using?
So that is why I usually use continuous infusion for procedures that I cannot expect when it will end. So,
Right.
and yeah, so, but what the regimen of propofol and ketamine, what I told people is just a recommendation, and as aspect of drug metabolism, propofol has short context-sensitive half-life, but ketamine does not. So when we continue the infusion prolong more than 1 hour or more than 2 hours, the effect of propofol will increase and the effect of ketamine will rise up to high. So that will make some problem. So
Right.
so when the procedure, so my answer is when the procedure is prolonged, uh, or when the procedure seems to prolong, I use continuous infusion, and when it has some time, and then I decrease the dose, the decreased infusion rate, so that I can manage the patient. I can maintain the spontaneous breathing. Yeah, that is my answer.
Can I just ask, do you foresee, because if we use ketofol in general, the anesthetist has to be there. Do you see a way in which we could sort of empower the pediatricians on the wards, the oncologists, to do some of this procedural sedation?
Mhm. So, in fact, in our hospital, the pediatrician do not use propofol. They only use chlorohydrate, which is oral agent, and midazolam and ketamine. That three drug is only drug they use during when they do sedation, and when that drugs does not work well, then they contact us anesthesiologists, and we bring some pumps and we bring propofol or other drugs with some rescue drugs to sedate the patient. So uh, many researchers says that infusion of propofol in pediatric patient shows a good result, but in real world, yeah, something happens, respiratory depression or yeah, cardiovascular collapse. That happens, and at the time, that is not good. So yeah, in our center, we only pediatric anesthesiologists use propofol, and the pediatricians maybe need some education or experience with us Yeah, that's what I think.
Fair enough. Fair enough. There's, I think it's a follow-up question on what we have been talking about, which is ketofol. So, the question is, how long is the lingering effects of ketamine post-procedure?
Post procedure. So,
Yeah.
because I have experience in GI endoscopy or muscle biopsy, which I can see the field. So I usually begin with high dose, which when they enter the endoscopy to the patient or when they cause some incision to the skin. And after that, I want to maintain the infusion rate as low as possible. Yeah. So minimal movement is fine when we do endoscopy or a little procedure. So I usually decrease the dose as low as possible, so that uh, the patient can maintain the vital sign, respiration, and recover fast. So usually they stay 30 or 60 minutes in the PACU after that procedure, and usually they do not show any pain or so. I think I'm not sure, but maybe uh, the effect of ketamine in anesthesia remain about 30 or 60 minutes. Yeah. So yeah, they are very comfortable at PACU.
Thanks for that. We have time for a few more questions. Another question from Tandong Yong. Any thoughts on propofol infusion syndrome?
Mm. So usually when the procedure needs more than 1 hour or 2 hours or 3 hours, that is not a good case for sedation. Then needs general anesthesia. So because we usually sedate patient less than 1 or 2 hours, that kind of duration is well tolerated by the patient, and yes, yeah, that's my answer.
Great, thanks for that. You did mention earlier that you do quite a few endoscopic procedures. In those procedures that you've done before, have you observed? I know you said that they're just relatively short procedures. Have you observed propofol infusion syndrome in this cohort of patients?
So my question is, I have never observed the proper infusion syndrome, but in our center, we use total intravenous anesthesia for neurosurgery. So when they use EP monitoring, we use propofol infusion. Uh, so sometimes it is more than 10 hours or more than 20 hours in our center, but they did not show propofol infusion syndrome after the surgery. So we use target controlled infusion for propofol infusion because we use continuous infusion that very long duration of propofol infusion can accumulate the dose, and so we use some pumps and our model to infuse the propofol with target controlled infusion. So that is why I think that that's the reason I did not see some propofol infusion syndrome. Yeah, that is my answer.
Um, I guess this is just a question from myself. With the advent of the COVID-19 pandemic, did you see any or were there any changes to practice in your institution or in your own practice with regards to procedural analgesia and sedation?
In fact, because our center is the highest tertiary center in Korea, severe cases came to our hospital, and so when our defense is wrong, something big can happen. So we test every patient and their parents when they need admission or when they need some treatment. Uh, so they have to do the PCR test before admission and even the day surgery. Yeah, so that takes time, and sometimes we have to wait several hours for the result, negative result before sedation or surgery.
Sure, thanks for that. I guess we're all in the same boat when it comes to the pandemic. Do you have any other questions from your end, Angela, that was sent to you?
No, no, I'm
No?
good. Thank you.
Okay, all right, good. Dr. Jang, we have a couple of minutes, so do you have any parting words or advice before we change over to the next speaker?
Oh, so first, thank you for asking me to the lecture. But uh, I think that we pediatric anesthesiologists can do very important thing during pediatric treatment, because when they cannot do MRI scan, when they cannot do biopsy, when they cannot do endoscopy, the treatment cannot proceed. So I think that we are doing very important thing, and hope that you all do well and yeah, with this area of pandemic. Thank you.
Thank you. Thank you very much, Dr. Zhang, for that talk.
Thank you. Should we move on with our story? Thank you very much for that. Very interesting discussions and talk so far. We now continue with Little D's story. Keep me company. So, when Little D's doctors saw her scans, they realized they would need more tests and that Little D would be in the hospital for a while more. Through it all, her pain became worse and worse. In fact, she had a few different types of pain, which were all different types of monsters to her. The monster who zapped down her leg fast as lightning when she moved. The monster who gnawed at her bones in her hip at night and grumbled in the day. The monster who punched her repeatedly in the buttock. She couldn't move in bed, she couldn't stand, and she couldn't walk because of these monsters. The good thing is that little Dee had a pain doctor in her hospital, a kindly woman who knew to ask the right questions to identify these monsters. This doctor also knew how to use her twin weapons of opioids and adjuvants, and some other things besides that, to keep little Dee as comfortable as possible while she underwent treatment. With us today is Professor Sushma Bhatnagar. She heads the Department of Onco-Anesthesia, Pain and Palliative Care at the All India Institute of Medical Sciences. She will in a while talk about judicious use of opioids in pediatric cancer pain. She is also the chairperson of COVID services in the same hospital and also the founder of the Cancer Treatment Center Project for Pain Free India. Prof. Sushma Bhatnagar is very accomplished and continues to do so in the field of pain. She is an IASP Council member and is a part of the Lancet Commission report on Palliative Care Implementation Task Force. She is the recipient of many awards, including the Leadership and Excellence Awards among SARC countries, as well as the IASP Award for Excellence in Clinical Research, Practice, and Policy Change. She is very well published and has given many, many talks. Today, she shares her knowledge and extensive experience on the judicious use of opioids in pediatric cancer pain. Professor Sushma Bhatnagar, the stage is yours.
Good morning, everyone. First of all, I would like to congratulate and thank organizers of ASPA for inviting me and for an important topic which really require discussion and which really require that we have to have an improving knowledge. Judicious use of opioids in pediatric cancer pain. So we all know that pediatric cancer pain is the important entity and we must know how to manage this. First of all, nothing to disclose. My flow of presentation will be how important this problem is, what is the magnitude of problem, then steps of opioid safety circle, what are the WHO recommendations recently, and summary. So first we will discuss the magnitude of problem, why they have this topic we are discussing today. Because we have seen the opioid crisis in developed countries and all over world recently. And these are the few photographs, opioid epidemic in children. It was not only in adults, even the children were affected. And children of the opioid epidemics are flooding foster homes. America is turning a blind eye. Something like this. These news we have seen and we have gone through this phase. And in 2018, this article, opioids are killing more children and teens too. It's not only adults, and an opioid crisis has affected more than 2 million of children in developed countries. And then this article came in 2020, which says that children's cancer pain in world of opioid epidemic means when there is whole world is worried about opioid epidemic, what can we do that we can keep a balance of not allowing our children to suffer in pain? So there, what are the challenges and opportunities? Wonderful article, beautiful messages this article has given. So in nutshell, we have to learn how to use opioids safely, because if you see these two photographs of my patient, we just cannot relieve their pain without using opioids. The NSAIDs will not work, paracetamol is not working, we can't give tramadol, and these children, they need pain management. If they are crying, the whole family is crying. And number of incidents of this kind of pain in cancer patient is incidence varies from 40 to 78%. So we have to learn how to use opioids judiciously in children. So what we need to do? There is a problem of opioid epidemic, but there is a problem of opioid crisis, that people are not getting opioids when they are in pain. Children are not getting. So the most important, the thing which we have to hit is improve education. And where we have to improve education at mainly three levels: physicians and healthcare system, patients and caregivers, and public. So if we want to improve the education, this is the article which we have published, and I always keep saying that these 10 steps are required if we really want to use opioids judiciously. What are the 10 steps? First step is trust between treating doctors and patient. Developing trust between doctor and patient is fundamental when we are starting opioids for pain patient, because trust is essential, and when patient is trusting doctors, he will be able to disclose complete information efficiently. Second step is creating awareness about use and misuse of morphine among patients and their close associates. So we have to remove misconception, we have to improve training program, and we have to increase public awareness. Third thing is education and empowerment of physicians. There are physicians, those who are treating cancer pain, those who are treating children, but they don't know many of the important things which are required to know: pharmacokinetics and pharmacodynamics, where it is harmful, when we should not give, when it is required to give. So all these things we have to improve that. And most of the time what we found, that there is a limited pain management education as far as children are concerned. And there is also very important finding that inadequate, always children remains always undertreated, and there is always inadequate assessment. So there is a need to empower our physicians. Then prescribing opioids with full responsibility. If somebody is prescribing opioids to children, they have to take the responsibility. What responsibility you will have to take? That you have seen your children, you have seen your child properly, you have assessed properly, you have assessed the mental illness of child as well as family members, and You have given something, you have created a protocol that it will monitor properly. There will be a proper follow-up system. There will be a proper compliance system. If a child is having side effects, or if there are slightest of evidence or any indication of overuse or misuse, you should be taking a close watch on this, and you have to take the responsibility when you are prescribing opioids to any child. Make it available whenever it is indicated. This is also true that throughout Asia, and especially in low middle income countries, it is almost most of the time it remains unavailable to the adults. We can't talk about children. Children always remain undertreated and they always remain in pain. So it is important that whenever a child is having severe cancer pain or in the terminal stage of the disease, he needs opioids, and it should be available through licit channels. Otherwise, people will try to procure through illicit channels. And educating society is very huge about safe use of opioids. That we have to make, we have to remove myths and misconception that it only causes addiction and there are always misuse, overuse. It is there. So we have to say this to the public that it should not be used unnecessary through illicit channel. But when person or a child is suffering with severe cancer pain or is in the terminal stage of the disease, he or she should not suffer, and it is required that these child should need opioids, and they should be treated in a different manner. So we have to educate societies to remove myths and misconceptions. Safe dispensing at primary pharmacy level. So when a pharmacist is giving, they are the frontline workers and they are the frontline people, those who can prevent misuse, abuse, or diversion. So you have to give the full responsibility and freedom to pick up the patient, because ultimately it is your responsibility. Patient safety is your responsibility. And if any patient pharmacist is concerned or he is having any suspicion, then he should immediately inform physician. And for the time being, he should have a right to refuse medication if he is slightly suspicious about the intake of the medication. Then ultimately, stringent supervision is required, and supervision includes that we should have a clear-cut differential diagnosis in our mind, that when it is getting misused, when it is when patient is using patient's mood disorders, patient is having sleep disorders or disturbing memories. All these patients, if they are having, or patient is having ultimately using for not has understood the instructions properly. So all these things are your responsibility, and patient should be seen by their prescribing clinician on a regular basis for monitoring of their pain, functional status, mood, use of medications, and general well-being. So it is your responsibility that you should have a stringent supervision, especially in children who are in risk of developing abuse. And this is a very important, that ultimately it is not only the physical pain, and opioids is not the answer for all the pain. So it is important that what my child is thinking, what parents are thinking, why he is suffering, why he is in distress. So there are many other components, and you have to remove those components, and you should know how to handle those components by good communication and good counseling. So there is nothing more we can do. We must think of new possibilities of doing everything by counseling, by talking, by giving medications, and by treating other causes, or by using non-pharmacological therapy. So managing total pain by integrating, it's a holistic, you should have a holistic approach for pain management, and this is very important. Correct and timely use of intervention. Although there is not much evidence as far as interventions are concerned in children, but in case if it is anything is applicable, we should try to use intervention whenever or wherever it is applicable. Give written instruction of do's and don'ts. Whenever you are prescribing opioids, what a child or a family member should do, parents should do, and what they should not do. Everything should be written in their own language. What are the do's and don'ts when you are prescribing medication? So this paper should go with the patient and with the child. Follow-up at regular interval is most important. That this follow-up should indicate, it should be computerized, it should be on paper, whichever way you want to create your own system. But there should be a clear-cut follow-up, that a patient or a child or the parents, they cannot procure for multiple resources. So there should be a system that they will be procuring medication only from a single pharmacy, and there should be a follow-up that already on this date he has taken for 15 days. Now he's coming after 15 days. So exactly after 15 days, and he is requiring, and then you have to examine your child and assess that whether he's really requiring medication further. So it is very important that you have to have a follow-up at regular interval. Improving nursing education makes a huge difference. So when your nurses are educated, they will also be educating, because 24 hours they are with your patient. So they will also be educating your the parents and the child that what are the disadvantages of underdosing, and what are the disadvantages of overdosing, and what are the disadvantages of underdosing. So they will also be teaching parents and the child about the safe dispensing and safe using practices. So it is important that your all nurses should be educated about the opioid dispensing and safe use of opioid practices. This is the opioid safety protocol. This is one protocol, but I am not saying that everybody has to use this protocol. But the principle that good patient who is requiring opioids should be there should be full education to the patients and physician. There should be a good communication and consent, and there should be a good comprehensive pain assessment. Whenever you are starting opioids, there should be a plan to revisit, monitor, surveillance, and referral. So it is important that you have to have a good protocol in place whenever or whichever circumstances you are working. WHO in 2020 also given a recommended for cancer pain principle of opioid stewardship. What is the essential practices opioid stewardship in children? They included that opioid must only be used for appropriate indications and prescribed by trained providers with careful assessment of benefit and risk. The use of opioids by individual, their impact on pain and their adverse effect must be continuously monitored and evaluated by trained providers. Then they say that the prescribing provider must have a clear plan for the continuation if it is required, tapering when disease is in control, or discontinuation if he is completely disease free or pain free of opioids according to the child's condition. Child and family must be apprised of the plan and its rationale. There must be due attention to procurement, storage, and disposal of unused opioids. So these are the important points which WHO has given in the guidelines and management of chronic pain in children in 2020. So it is a very important, and basically ultimately it is your responsibility. You have to educate society, you have to educate children, you have to educate parents, and you have to make them understand what is the use and what are the disadvantages of misuse. This is just last 5 years data of our own hospital. We see 10,000 patients per year, and this is the data of 5 years where in 316 patients we have seen patients for pain management, and 270 patients received opioids in. And what I have seen that out of 270 patients, they were almost every patient was on their terminal stage of the disease, in the last end stage of the disease. And so it is important that we are not giving all 10,000 patients medication opioids, but if we are seeing 1,000 patients in 5 years, children, only 316 patients were in end stage of disease, and out of 316, 270 children only required opioids for pain management and reduce suffering for them. So learning use of opioids at every stage is very important. Again, the same photograph, we cannot keep them quiet. They will keep crying, and the patients and their relatives or parents will keep crying when child is crying. And it is important that every child who is in pain should smile at least, because they are very clear soul, hearted soul. If they will remain pain free, they will start playing, and the parents will have a peaceful time. So it is important that we should learn how to use opioids in every. This is a father of a child who came to my clinic, and he said that I know that he is not going to survive. I'm not worried about his death, but I just want that he should not die in pain. So if this kind of patient will come, and if you don't know how to use opioids, you will not be able to relieve their pain. So for my suggestions, there should be a separate OPD register for PC and end of life care. Communication skills improvement program should be there. Training of nurses is very important. Awareness of resident doctors, those who are working in pain clinics, they should be aware. Residents rotational posting should be there. Other department, those who are looking after children, they should be have a rotational posting wherever the pain management program is going on. Specialist consultation is required on request, and there is a need to make guidelines. And we are not, I'm not suggesting that this guideline is better or that guideline is better, but principle remain the same, that we have to make a balance of use versus overuse or misuse. And this is my last slide, the concluding slide, that pain is a serious consequences of cancer. Children always remain undertreated. Opioids are the cornerstone of treating severe pain, especially in end stage of disease. Well-controlled pain improves compliance to treatment. Adequate pain management improves quality of life, not only children, but also the parent. There is a strong need to improve education at all the levels, and we need to make robust program based on our available infrastructures, and we cannot allow our children to suffer both ways by having opioid crisis or opioid epidemic. Thank you very much.
Hi, Prof. Sushma. Thank you so much. It is such an honor to have you speak to us here. So Kim, I think your camera's off. All right. Okay, I think there are a few questions. Kim, do you want to kick off with some of the questions?
Yeah, sure. Thank you very much for that, Professor Batnagar. I love how you not just discussed opioids practices, but you also sustainability of the practice as well and workflow. So thank you very much for those. I'm sure a lot of people will find that very helpful, as I do. All right. To start off, my initial question in the rest of the questions will probably follow from this is how do you do opioid rotation? Which opioids would you use first?
So for opioid rotation, as far as is concerned, we usually titrate with morphine because
Mm,
it is a short-acting opioid available. So
mm-hmm,
once we are sure that for particular dose is giving good pain relief to to the child, then we convert it to the usually with the, because now we have only two opioids available in our country, that is morphine and fentanyl. So we convert to the
mm-hmm,
fentanyl. Otherwise, we continue with morphine. We prefer to continue with low immediate release or slow immediate release morphine, short acting morphine, so that the titration is better and the management and compliance is better. But in rare circumstances where it is contraindicated, we convert it to fentanyl patch.
mm. Okay, all right. Thanks for that. So currently there are two opioids
Yeah,
where you are practicing at.
methadone is recently has been it has been approved for pain
Mm-hmm,
management, but it
mm-hmm.
is not widely used all over India.
Right. Okay. If you would be using methadone, how would you suggest it be used? So
So for
some person,
methadone,
yeah.
for methadone, we prefer that patient the child should be admitted in the hospital, and once we have titrated the dose of methadone, we would like to have a follow up in a short interval so that we know that how they are doing, and we will not like to keep it for a long time. Miss like for months together, we will not give the doses from home. So we will like to have a follow up maybe in a week or 2 weeks, and we will like to see that whether how he is doing. So most of the time, in very few children we have used it, but we keep a very close follow up, more than what is required for morphine and fentanyl. We keep
Mm-hmm,
further close follow up with methadone.
mm-hmm. Okay. Many thanks for that. So most of these patients would probably be on opioids for quite a long time. Do you see any side effects when it comes to managing patients who are near the end of life with use of opioids? And how would you be managing those side effects, if any?
So, at the end of life, if we are starting opioids, I think we are not, most of the time, what we see with the most important complication which really bothers to parents as well as children, that is constipation.
Mm-hmm.
Constipation is a big becomes a big problem, and
Mm-hmm.
sometimes they also feel nausea, vomiting, and nausea. Most of the time they feel vomiting. Rarely they feel, but we manage with this with nausea, vomiting, and the constipation aggressively, so that they should not have this problem. Regarding opioid overuse and misuse, I think we keep a close follow up, and most of our children, when they are disease free or disease burden is less, we taper the doses, and sometimes we switch off the opioids.
Okay. All right. Out of interest, you did mention opioid misuse and abuse. Have you experienced any instance or situation of opioid misuse and abuse amongst cancer patients, the pediatric
Uh,
population? Yeah.
in pediatric population, no, I have not seen any abuse
Mm,
and
yeah.
misuse. It makes a huge difference that when you are closely following up, we you are you are very aware that disease is not progressing, disease is in control, or disease in remission, if the child is disease free. You
Mm-hmm.
yourself is required to reduce the doses, so that this type of problem will not come. If you will keep them loose, then definitely this problem can occur.
Mm-hmm. Thank you very much for that very, very practical approach again. A follow-up question to methadone. Do you use methadone as a first line or just a rescue for prolonged morphine use? So this is a question from Dr. Teddy Fabula. As far as I know, the onset of methadone is not as fast as well as the excretion.
So absolutely right that we first line opioid is only morphine, is morphine.
Mm-hmm.
So by all means, so methadone rarely we are using when there is a problem with kidney function or something, but definitely with the titration, after titration with the morphine doses. It is never the first line dose.
Yep. Okay. Thank you for that. Another question: how is your experience with transdermal patches like buprenorphine or fentanyl?
Buprenorphine we don't use in children.
Mm-hmm.
Fentanyl definitely we use. There are patches available with 12.5 microgram and 25 microgram. Most of the time, children will not go beyond that this dose. But again, there is a problem with the fentanyl use, that at the end of life, most of the time these children are having temperature off and on. So we will not like to use fentanyl regularly, or we will again switch to the morphine, because the absorption of fentanyl will become erratic when the child is having temperature. So again, it will not be a choice of pain reliever in children at the end
Mm-hmm.
of life. Child is having off and on fever. So fentanyl is used, but again, our 5 to 10% of children they are on fentanyl, and but we try to either switch it off when disease progression is less or when disease is under control. We will not like to continue for a long time at home that they keep using fentanyl patches, because we
Mm-hmm.
are aware that there can be a problem with the uses, and there can be a misuse. So we are aware. And titration and compliance of both is better with the short acting opioids, that is
Mm-hmm.
morphine.
Okay. Um, just a question for myself. Have you encountered opioid hyperalgesia in these patients? And how do you manage those situations?
So opioid hyperalgesia is I have not seen in children. But when there is a severe neuropathic component with the some tumor which is compressing the nerve or destroying the nerve, and child is on morphine and it's not getting controlled, we think that it is opioid hyperalgesia, and we have changed the opioids. This is opioid rotation. We rotate the opioids, but most of the time it does not work. So in I have not clear cut seen incidence of opioid hyperalgesia in children, but definitely in adults we have seen, and opioid rotation is the answer for opioid hyperalgesia.
just a last question, sorry, and just to follow up on that, because we are probably in the same situation where we have limited opioids at our disposal. What do you do if you, say, for example, encountered that situation and have exhausted the opioids that you could rotate to?
Oh, this is a terrible situation many times. This usually I have told you in the 10 steps that we should have an uninterrupted supply of opioids, because when a child is dying and in having intractable pain,
Mm,
this is the only thing which is going to give them relief. But rarely in initial days, I think because I can imagine that this is my experience of 2.5 decades. And but initial days, it used to be sometime there used to be a 3 or 4 days. It is there is a gap, and if we are not getting opioids, then we try to manage pain with fentanyl, and we try to manage pain with ketamine and propofol
mm.
something, but it does not work and it is not an answer. So it is always better to have a uninterrupted supply of opioids in your center.
Thank you very much for those suggestions and very practical ideas again and practices. Angela, do you have any questions from your end that you can't see and I
Yeah,
sense
yeah.
from the chat?
Dr. Tay Peng Leong has also asked for pain control. Prof. Sushma, I know you don't work so much with oxynorm, but do you know whether there are any real, like, major differences between maybe oral morphine and oral oxynorm?
So, see, I have read papers and on oral oxynom. So there is no much difference, but the principle of safety remain the same whether we are using oxycodone, oxynom, or any other morphine or any other opioids. Principle always remain the same, that we have to take all the responsibility on us, that it should be used safely, it should be used to the right person, it should be used in a manner where there is a close follow up, and whenever it is not required or a disease is not progressed, disease is under control, we have to taper it off. So the principle remains the same. Pharmacokinetics and pharmacodynamics of various opioids are different, but definitely uses principles remain the same.
Thank you for that. I think we have one more minute. Do you have any parting words, Professor?
So my message again will be the same, that we have to make a balance. There is a problem of overuse, or like in from the form of opioid epidemic, and children are the most vulnerable group, where if we will not keep a close watch, it can become a huge problem for all over the world. But simultaneously, this is also true that there are not many options for managing pain in our children. We can't use tramadol, we can't use codeine, and when child is in extreme pain and when they are dying or they are in the end stage of the disease, they really suffer, and when they are suffering, their parents are also suffering. So we should know how to make a balance and how to use safely in children, so that we can give them relief. The parents will be relieved and child will be relieved, and they can have a dignified end. So this, they will not feel guilty at the end of that my child died in pain. So this is very important, to have a balance and to learn a balanced use of opioids.
Very well said. Thank you. Thank you very much.
Thank you very much.
All right. So I'm still reeling from the interaction there. Sorry. This part of Little D's story introduces us to our last talk of the morning before we break. Let me introduce Professor Stefan Friedrichsdorf, who will talk on adjuvants in pediatric cancer pain. But before that, going back to Little D's story, an adjuvant is a medication not classified as an analgesic, but through its action lends to analgesia. Antineuropathic agents, muscle relaxants, and anxiolytics all feature and were considered in Little D's case. Professor Stefan Friedrichsdorf is a professor in pediatrics and is the medical director of the Center for Pediatric Pain, Palliative and Integrative Medicine at the UCSF Benioff Children's Hospital in Oakland in San Francisco. It has one of the most comprehensive programs in the country. It has received the prestigious Child Kind International Pain Relief Certification and the Joint Commission Palliative Care Certification. He received his medical degree from the Medical University of Lübeck in Germany, completed his pediatric residency at the Children's Hospital in Dayton, also in Germany, and undertook his fellowship in pediatric pain medicine and palliative care at the Children's Hospital at Westmead. He also received the 2016 Elizabeth Narcissian Award for Outstanding Educational Achievements in the Field of Pain by the American Pain Society, as well as the Hastings Center Conniff Dixon Physician Award. He was the medical director of the Department of Pain Medicine, Palliative Care, and Integrative Medicine at Children's Minnesota from 2005 to 2020, and under his leadership, the department grew into one of the largest and most comprehensive in the country. He has been and continues to pioneer and be part of pediatric and palliative care education programs which have trained hundreds of clinicians in different countries. He is very well published and has multiple contributions to many books. Lastly but not the least, he has also had a colorful, non-clinical career. He has worked as a newspaper delivery boy, tour guide, factory worker, youth group leader, not particularly talented actor, assistant nurse, journalist, paramedic, EMT, lifeguard, and children's theater director. And he is happily married to Ruth, who, according to him, is a much better pediatrician than himself. And they live with their 3 children in the groovy Bay Area. Dr. Friedrichsdorf, welcome to ASPA, and I give you the stage. Thank you very much for coming.
Hello, fabulous people at ASPA 2021 in Singapore. Kind regards from San Francisco. My name is Stefan Friedrichsdorf. I am the medical director of the START Center for Pediatric Pain, Palliative and Integrative Medicine here at the UCSF Benioff Children's Hospitals. And it's my great pleasure, and thank you so much for the invitation, to talk about neuropathic pain management and adjuvant analgesia in pediatric cancer pain. And I thought what we're going to do for the next 29 minutes is to think about a step-by-step treatment approach for neuropathic pain in kids. So following my the previous presenter, let's look into a 3-year-old girl by the name of Lexi. She weighs 15 kilograms and she has left lower leg osteosarcoma. She has developed mixed acute neuropathic pain and has been in the hospital for complications of her illness. And at home, she displayed intractable pain behavior per oncology team. So she's your patient. And her mom and her grandmother just showed up in the emergency room and wanted to talk to you.
Lexi was up all night. We got no sleep. And that medicine, it's making her sicker. It's not making her better.
Settle down. Settle down, Jim. We're doing the best we can, but Lexi is a lot to take care of. And she needs us all the time. I'm working nights now, so I watch her during the day, but it's too much. She doesn't ever rest well. She's crying all the time, and she's constantly bringing up this gunk. Plus, Jennifer's falling behind in her classes, and if she drops out now, that's really going to be bad for Lexi and her brother, Bobby. She's missing a class right now.
Can you describe her episodes a little bit more for me?
We try to settle her down, but nothing works. None of us has slept in 3 days. She constantly cries. She has to work nights. I have to go to class. And she just cries. She never sleeps. And when she does sleep, she'll sleep for like 1 minute. And then she makes this gasping noise and she wakes up again.
And when she does, it's so scary when she's like that. And the liquid medicine that she's using, it knocks her out too. And we're scared when she won't wake up, so we stopped using it.
She may be fighting a respiratory infection, like a bad chest cold. With antibiotics, we hope that will improve in a few days.
What are we supposed to do, Dr. Rao? This is too much.
What are we supposed to do, Dr. Horace? This is too much. So your exam and taking the history suggest mixed acute and neuropathic pain. So what are the next 11 steps of an appropriate treatment plan? And I give you 5 seconds to think about that. All right, step 1, as always, is the evaluation. We have to take a history. We do need to perform a clinical exam and undertake medical tests only as they are required to get a better idea of what really is going on. Pain is a symptom. Pain behavior is a symptom. And we have to understand, is this pain 8 out of 10 acute pain? Or is this chronic pain? Is this total pain? Is this neuropathic pain? Is this visceral pain? How much of this is anxiety, depression, poor sleep hygiene, in older kids, school absenteeism? Could this be delirium? Could this be withdrawal? If we do not understand what's under the iceberg, what's under the surface of the water of this iceberg, we may not be able to treat this appropriately. And then, of course, we always want to treat underlying causes first, if this is within the goals of care for this child. And we are really certain that this is something we might have a good chance of getting better. And when we have kids like Lexi, 3 years old, with pain behavior, and we're quite certain that a significant piece of this is neuropathic pain of her left lower leg, but could there be other issues? Might she be constipated and we have to treat aggressively her constipation? Could this be spasticity or contractures? Might this be in a non-verbal child, a seizure? Could this be the day and night rhythms completely out of whack, meaning the kids are sleeping all day and up all night? Is this a kid who is fed by a G tube or a J tube? So is this a feeding intolerance or visceral hyperalgesia? Is this delirium? We're just giving too much stuff. Yeah, could this kid be seriously nauseated? And if we don't assess and treat this appropriately, then we may not be successful in treating this pain behavior successfully. Step 3 is we have to, as there's no other way, must include integrative therapies. And there's, of course, so much more than emergency yoga. We're talking about offering age-appropriate modalities such as distraction, aromatherapy, massage, acupuncture, acupressure, guided imagery, self-hypnosis, dog therapy. So all that needs to be offered because it significantly decreases distress and pain. Step 4 is to include social work, to provide family support, psychoeducation, supportive counseling, parent guidance. In our little video vignette here, probably this family needs some respite. Maybe we would need to admit this child or have significant support at home to do this. We need, with our team, to provide help to manage comorbidities, anxiety, depression, sleep disturbances, school absenteeism, and so on. And key, of course, is also to have a psychologist, a therapist, child life specialist, access to spirituality as part of the treatment program. And exercise, rehabilitation, seems to be absolutely key in treating successfully neuropathic pain. And you probably want to talk to your favorite physiotherapist or physical therapist, whether they are already including graded motor imagery. So that's the process of thinking about moving without actually moving. So this, for instance, is a 7-year-old boy with phantom limb pain with osteosarcoma. And using the mirror, he can practice his left arm and to treat the pain in his non-existent right arm. So make sure that mirror therapy is part of the treatment program in your institution. So we haven't talked about medications yet, and there's a reason for that. Medications alone are not sufficient in more than half of pediatric patients with neuropathic pain. So if you are hoping you're listening to like a half-hour talk from me, and then I just give you like the right mix of medications and then you're done, I can't give you that. Yeah. We know from adults and we know from pediatrics that medications alone will not be helpful in more than half of the patients unless you combine it with physical therapy, occupational therapy, and psychology, using integrative non-pharmacologic modalities. And we sort of need a step-by-step approach with medication. And a common mistake is we try something, it's not working, then we stop it. And then we try something else, and it's not working, we stop it. For neuropathic pain, that doesn't work. So we're going to talk about that. So what about step 5, basic analgesia and opioids? It seems, and I go quickly through my slides, but you have those in your handouts. So if you have any trouble falling asleep tonight, you're very welcome to look at the slides. That NSAIDs such as ibuprofen actually quite effective in treating neuropathic pain, and much more data in your slides. For new onset of neuropathic pain, opioids are indicated. So if we have a patient who has, say, vincristine or cisplatin, chemotherapy-induced neuropathy, and that started last week Wednesday, or a child who has new onset of a metastases pressing on the central nervous system, or as in our case, on the left lower leg, and this all started a week ago, then opioids are very appropriate to use, and we would maybe think about tramadol as a weak opioid, and a mixed analgesic. We may think about methadone, which often is magic in treating complex pains. But even immediate release opiates such as morphine are very effective. For long-standing neuropathic pain lasting more than a month or 2, opiates usually are not indicated, and we would wean them off and discontinue them, unless this is in a child with advanced pain entering the end-of-life phase, where methadone then would be very appropriate to continue. So step 6 is gabapentin and amitriptyline, so gabapentinoids and tricyclic antidepressants. And an appropriate amitriptyline dose for Lexi, assuming her EKG doesn't show significant QTc prolongation, is low dose anywhere between 1.5 to 6 milligrams. If you have a teenager more than 50 kilograms, then of course you cap it at 50 kilograms, and you may start somewhere at 5 or 10 milligrams once at night and go all the way up to 20 or 25 milligrams. Going higher does not provide you more analgesia, you only get more side effects. So this is why we talk about low dose tricyclic antidepressant. You can switch from amitriptyline and nortriptyline at the same doses, and in your slides, more information about those tricyclic antidepressants. Gabapentin probably is hands down one of the most commonly used medication we use as an adjuvant. And even for neuropathic pain, it appears to be very effective. There is some studies showing that it's not as a single medication, and that's probably true. As I talked earlier, if you use one medication alone, it may not be helpful. It's more like building a barrel, and in order to keep the water or whiskey or coffee or red wine or whatever your favorite beverage is within that barrel, every single of these planks outside of that barrel has to be built. So it's not gabapentin is not working, let's stop it. Oh, amitriptyline is not working, let's stop it. You start gabapentin, then you add amitriptyline, then you may add clonidine, you add physical therapy, you add psychology. So you build your barrel and keep those things on and just don't take them away. More information about gabapentin in your handouts. Pregabalin is probably not better than gabapentin, so we usually use that second line. If you have dose-limiting side effect with gabapentin, you may consider switching to pregabalin. And what would be an appropriate dose for gabapentin? Again, in your handouts, you find dosing recommendations for all those medications. So we may start with 90 milligrams every 8 hours and go up to 360 milligrams every 8 hours. Every 8 hours is usually better than 3 times a day, because otherwise you have 12 hours overnight when no medication is given. For a teenager more than 50 kilograms, you may start the 300 milligrams and then slowly go up to 1200 milligrams every 8 hours. If this is a teenager still going to school, then you may start lower with 100 and slowly go to 200 and 300 to avoid oversedation. For infants, babies, and I certainly have used it for infants, term and older, we usually schedule this every 6 hours, because 8 hours is just not long enough. And again, you have some starting doses for infants in the first year of life in your handouts. And as I mentioned earlier, tricyclic antidepressants such as amitriptyline, nortriptyline, and gabapentinoids such as pregabalin and gabapentin work completely differently at different parts of the pain nociceptive system. So combining them gives you a better chance that they're working than just starting one, stopping it, and starting the other and stopping it. The next step, and something I certainly use a lot, and we use a lot at our center, are alpha agonists. So that is dexmedetomidine and clonidine. Dexmedetomidine is nicer intravenously, easier to titrate, has a greater A2 versus alpha-2 versus alpha-1 selectivity, and then clonidine. However, it's very expensive. It can only be given intravenously, and in many centers it can only be given on intensive care units. So the cheap and pretty good version then is clonidine, and more data in your sign-outs for that matter. This is a study we published with more than 100 kids from newborn 33 days old all the way to 17 years. And we actually used much higher doses than originally approved for. We could usually start at 0.2 micrograms per kilogram an hour and go all the way up to 2 micrograms per kilogram an hour, carefully titrating to effect, making sure that kids are not over-sedated unless we want sedation, and don't have alpha agonistic side effects such as bradycardia, junctional rhythm disorder, or hypotension. More in your handouts, and for that matter, also 2 studies showing that the effectiveness of using dexmedetomidine in neonates. Clonidine is something we use quite a bit, and we basically either use a tablet or a liquid, and patients can also swallow the intravenous liquid, and usually a normal starting dose is about 1 to 3 micrograms per kilogram every 4 to 6 hours, either as needed or scheduled, depending on the demand. And of course, you watch for the same side effects I just talked about with dexmedetomidine. When you want to switch dexmedetomidine Precedex to clonidine, this is something we commonly use depending on whether a patient is using low, medium, or high dose dexmedetomidine. Then we give 1, 2, or 3 microgram per kilogram of clonidine every 4 to 6 hours scheduled. And that sort of allows us a rapid titration of the dexmedetomidine within 24 to 48 hours. The next step, and something we also use a lot, is our NMDA receptor channel blockers. So those N-methyl D-aspartate channels can be hopefully effectively closed with a whiff of a splash with ketamine. And low doses anywhere from 1 to 5, all the way to 10 micrograms per kilogram a minute. So that for a teenager would be a starting dose of 3 milligrams of intravenous ketamine per hour, titrating up all the way to 15 or sometimes even 30 milligrams per kilogram an hour, has been shown to be opioid sparing and a very, very effective adjuvant analgesics, not only for neuropathic, but also for visceral and acute pain. Much more data and information on ketamine in your handouts, and I added some slides on there at the end. And then step 9 would be to think about sodium channel blockers. So we use quite a bit of transdermal lidocaine. There are patches, 4% and 5% patches, which come in the matrix form. You can actually cut them to pieces and put them on the outside at the area where the local pain is. And it's unclear how much of that is really a placebo effect and how much of this is really effective. But it's something a significant number of our patients tell us that they find this to be very, very, very effective. So again, we are working on sodium channels, especially NaV 1.7 and 1.8 channels, and for that matter, in your handouts, again, some experience with intravenous lidocaine. So we also have a policy. It's not very user-friendly. You have to take the levels every 8 hours and then titrate it into effect. So therefore, this is usually something we usually use after an alpha agonist, such as dexmedetomidine or clonidine, and after we've used low-dose ketamine. However, it's something which is quite effective in kids with several pain disorders. And then, of course, I'm speaking here to the experts. Never forget regional anesthesia, such as a neuroaxial infusion. So this is a patient of ours at my previous institution, and I would like to thank my colleague, Dr. Adam Sturman from Children's Minnesota for taking those videos, and it was his patient. And so this is Daddy, who's a 3-year-old with a rhabdomyosarcoma of the left hip and thigh. And this tumor eventually metastasized all the way to his lungs. And despite very high doses of opioids, including methadone, he had adjuvant analgesia, sedatives, he either required moderate to deep sedation or he was in significant intractable pain.
Say hi, Dougie. Hi. How are you doing today? Can you give me a smile? Can I see a smile? There you go. There you go. That's so.
So this is Dougie's grandmother and her primary caregiver.
Hi, I've been Douglas's caregiver for the last 2.5 years, and he's had many different procedures. But this last week, we went through a very bad bout of pain and irritation and anger. And we came to the hospital and they performed epidural on him, which relieved just about 99% of the pain. He's eating, he's sleeping, he's playing again. So I would highly recommend taking and trying different options.
So he received an epidural, right? And suddenly had stunning analgesia. And
like that. Bubbles. You say bubbles? Daddy loves bubbles.
he was then sent home with a tunneled catheter with an epidural, something then, if taken care of, can stay in for weeks or even months in his case. And he was enrolled in our palliative home care program, and he died comfortably at home. And his family is very happy that his story is being told. In your handouts, more information about regional anesthesia approaches, such as central neuroaxial infusions, peripheral and plexus nerve blocks, neurolytic blocks, and even thinking about implanted intrathecal ports or pumps for baclofen, opioids, local anesthetics, or other adjuvants. And lastly, step 11, there are other adjuvants you may want to consider if the first 10 steps are not working. A whiff of a splash of benzodiazepine, like low-dose diazepam or low-dose lorazepam or midazolam, might be quite effective. Thinking about an SNRI, such as duloxetine. Again, if the child is significantly has anxiety, depression, you're probably more effective with using an SSRI, such as something like sertraline or citalopram or fluoxetine, plus using cognitive behavior therapy. And we are less excited for sort of the adult data using duloxetine and SNRI when we're hoping to sort of treat both anxiety and neuropathic pain at the same place. However, it's worth considering. There's good data that Botox, botulinum toxin A, regionally given at the location of the neuropathic pain is quite effective. That's something to consider. Of course, going back to our case, Lexi, who has mixed acute and neuropathic pain in her left lower leg due to a tumor, palliative chemotherapy and palliative radiation or surgery might be then the way to go. And lastly, something we found to be very, very effective is is actually giving low-dose propofol. So giving a whiff of a splash, we're talking starting with 0.5 milligrams of propofol per hour. and then titrating effect at a stage where where patients can still talk and walk around, has been published, and we have published 9 cases from our institution, its effectiveness of managing intractable pain or intractable nausea in situations of advanced cancer and end-of-life situations. So, coming to the end, and in conclusion, I hope I could convince you that neuropathic pain is common among our patients. It's often underassessed and it's undertreated. And we want to treat underlying causes if it's possible and if appropriate. And I hope I could convince you that thinking about a careful step-by-step approach, and in that we must, as in have to, as in there's no other way, combine integrative modalities such as hypnosis, aromatherapy, massage, acupuncture, with physical therapy and exercise, with using psychology, social work, and all that together with pharmacology and interventional therapies is much more effective, as if we're just putting all eggs in one basket and just using one modality. But medications alone are often ineffective, and a common mistake is to try one, it's not working, then stopping it, and then basically starting another one which is not stopping, then adding it, and then giving it as needed as opposed to scheduled. So we really have to do a step-by-step approach, and thinking about the barrel being built out of different planks, and one plank has gabapentin on it, one plank has amitriptyline on it, one has methadone on it, one has low-dose ketamine on it, another one has psychology on it, another one has acupuncture, a different has massage or a dog therapy. And as we build this barrel, we will eventually be able to keep the milk, the red wine, the whiskey, or the coffee, or whatever your favorite sake, whatever your favorite drink is, inside that barrel. First-line medications are usually low-dose amitriptyline and gabapentin. Opioids are indicated for new onset neuropathic pain very much. They're usually not indicated for long-standing chronic neuropathic pain, unless it's caused by growing solid tumors, as it is in our case here. Of 3-year-old Laxi. Think about dexmedetomidine or clonidine and low-dose ketamine at sort of your next steps. And hopefully regional anesthesia rocks, so that keep that in mind. And with that, I'd like to invite you to attend other conferences, both the Pediatric Pain Masterclass, which I'm leading here in San Francisco, both virtually in December, and then next year, December, in person and virtually. And I hope to see you at the International Symposium of Pediatric Pain, which is virtually at from March 24th to 27th in Auckland and New Zealand. And with that, thank you very much for your for participating and listening to me. And I wish you a great, fantastic continuation of your conference. Bye-bye, and all the best from San Francisco.
Thank you so much, Prof. Good to see you.
Good to see you, lovely people.
Thank you. So much knowledge, so little time. Thank you so much, Stefan, for sharing with us and taking the time out of your incredibly busy schedule to be with us today. As a further introduction, Prof. Friedrichsdorf is also the current president of the Pain and Childhood SIG of the International Association for the Study of Pain, and he is a highly dedicated professional who is passionate about pain relief for children, be it procedural, chronic, or oncopalliative. Stefan, maybe I could just kick off some of the questions by asking about your barrel in which you keep your whiskey. When do you know when to stop and when to press on with a particular anti-neuropathic per se?
So we don't know, right? So it's really something which you have to build the barrel together with the patient and with the family. And we know from adult data that single medications only have an efficacy of maybe 40% or 50% of making patients better by 50%. So they're not super effective. So we're really just hedging our bets. So we're putting gabapentin together with clonidine, together with amitriptyline, together with psychology, and we hope that finally we have enough planks for this. And I think we often tend to use something, it's not working, then we use something else and that's not working, and sort of add this on, and we just seem to be less effective. And by combining those modalities, we just have a much better chance. And it really often makes sense to make the plank really thick, so we're maximizing the dose of gabapentin before we're giving up. We're maximizing the dose and finding out, like, is there a way to get this better if this is truly this kinds of complex neuropathic pain.
Right. What happens in children who, because I'm sure you've seen a lot of kids who kind of psychologically or even physically sometimes kind of block you out as a physician because they're miserable, they're in pain. Even if you go there introducing yourself as a pain specialist, they kind of just shut you out and they're shutting the other therapists out. Do you have any advice in such patients?
You know, I mean, the putting ourselves in their shoes is like, what is their experience? Maybe the last 10 people who came through the doors were the one who poked needles into them. So they may not particularly trust me. So it's important to build some rapport and using hypnotic language. Hey, would it be okay if I stay around and help you to that until you're bothered less? Or like a version of this. Using childlike language may be a chance to get closer. I always have magic tricks with me. So I often start with a magic trick, which usually in the age group of 3 to 12 or 15, and sometimes even older, is something which is often a nice start and then makes them interested enough when I after done the magic trick to sort of talk about advanced pain or symptom management.
Right. Not to put you on a spot, but do you have any magic tricks with you now?
I don't sort of have any with like a common one I do is basically I sort of take out tissue and then basically say, okay, I ask the kid to take this. I'm going to make this go away in front of your eyes. Are you ready? And then I give it to the child. The child is going to put this sort of into my hand. And then I basically say, yeah, and then, okay, it's still here. So yeah, you still this on 3, basically gone. And then I go 1, 2, 3, and it's gone. Yeah. And and that, what I do is at 3, I toss it behind my shoulder. Yeah. So I go 1, 2, and at 3, I just leave it behind my shoulder. I come back with the empty hand and it's gone. Right. And that is just a simple trick you can basically do. And then they say, wow, okay, that pain doctor is different. Yeah. And then I may have a chance. It's not always working, but it works quite a bit.
It does help when you're incredibly personable and can do magic tricks. But for the rest of us normal human beings, would you say there are any particular sort of favorite complementary modalities that would be easy either for the physician to kind of advise parents to administer? Aromatherapies, any sort of massage things that we should be we can teach parents per se?
I mean, what everyone who's listening right now, what can you do tomorrow, right? It's breathing. Just inviting children and their parents to breathe in through your nose, out through your mouth, and do this 3 times, and making sure that each breath is deeper than the one before. Just use the word imagine. Imagine. Why are you breathing out? You're not in this hospital room. You're just at your favorite place. This, the magic of the word imagine, sort of can engage this. Aromatherapy, things like peppermint or orange or spearmint or lavender, it's particularly helpful for management of pain or insomnia. Acupressure points, so something like P6 we can use for nausea and vomiting, or certain headache points. So you basically talk to experts who are trained in acupuncture acupressure. That is something, yeah, you can train everyone in about 5 minutes. Those 3 acupressure points. Acupuncture, of course, not. That is far more complicated. I'm trained in hypnosis, so that is certainly something which is particularly helpful. And doing a hypnosis course really helps to engage with children. So it depends on the age. It depends on the child. I have a few apps on my phone which I can bring on and show to children then as well. Balloonimals is certainly one of my absolute favorites, where you basically, when for smaller kids, yeah, I can go on this and then pop on this. I ask them to blow in, and then when they do this, they blow this, right, and then so the kids can shake it, and the balloon becomes something much bigger, and then it's a kangaroo, and then they can touch it. So then they can, it sort of moves, and if they like, there's even a pump in the corner. They sort of can blow it up and until it pops. Yeah. So it's a very nice COVID safe app. Yeah, you just have to clean your phone afterwards. So having a few things, a magic trick, some breathing, an app in your phone helps to also sell some clonidine or some morphine.
All right. Thank you very much, Prof. Can I just ask, because we are a little bit limited on time, I would like to ask if we were to try to push for hospital management to be more inclusive, and what sort of integrative therapy should we be pushing for?
So you probably want to ask your staff what they're already offering. And I think it very much depends on your cultural background. What do your families actually like when you ask them? Most places seem to do very well with either acupuncture, acupressure, with massage, with aromatherapy, with music therapy, with breathing. So this seems to be, which seems to work in most cultures. Many of those things are not very expensive. This is something everyone, the nurses, the social workers, the child life specialists, the physicians can practice. And then, of course, you want to invite your hospital to hire some people who are actually doing this as their main job, and then can train the rest of the gang of the staff to use those modalities.
Right, excellent. There are some more questions actually, Prof, but Kim, do we have a bit more time, or do you reckon we should take this offline with Prof?
Yeah, unfortunately, we don't have any time left, but yes, there are a few questions. So maybe you can just answer those for us in the chat.
Yeah.
The group
All
chat.
right. So, Prof, we will email you the rest of the questions, perhaps, if that's all right.
Okay, I will have a look at the chat. Okie doke.
Thank you.
Welcome.
Is there anything you would like to close with? Some take-home message?
Just congratulations to having a conference in Singapore. Congratulations to having your special interest group on pediatric pain. Yeah, that is amazing for the whole of Asia, and we see each other live in the near future. Thank you for attending this conference.
Excellent. Thank you so much.
Thank you for your time.
Bye.
All right. So we've come to the end of a very exciting morning, Kim.
Yeah, there are so many new things, practical ones, which are pretty good, which are really, really good, because we are all in probably different stages or countries when it comes to pediatric pain management, service establishment. So I'm sure all of us can pick a lot of things from what we have heard today.
Yes, I agree. I think it's probably time now to take a break. Everybody have a nice, good stretch. We'll resume the pain track later on at about 2 o'clock, but in between there is a lunch symposium, I believe. So everybody can proceed on there. All right.
See ya.
Have a good lunch, everybody. Bye.